Hello, today I will discuss instrumental vaginal delivery, focusing on vacuum extraction, also known as Ventouse delivery. Operative vaginal delivery accounts for approximately 10 to 15% of all births worldwide, and vacuum delivery is an assisted vaginal delivery method in which a suction cup is applied to the fetal scalp to aid delivery during uterine contractions and maternal pushing efforts. It is performed in the second stage of labor when vaginal delivery is anticipated but require assistance. Now, types of vacuum in instrumental delivery. Vacuum assisted delivery use suction to aid vaginal birth. The type of vacuum is classified mainly by cup material and suction mechanism. Based on cup material, it is divided into two types, soft cup and the rigid cup. Based on suction mechanism, further divided into conventional vacuum, handled or manual vacuum, and the third is the special rotational vacuum. These are different types of vacuum. Now I will discuss an important concept vacuum assisted delivery, the flexion point. The flexion point is the ideal site on the fetal scalp where the vacuum cup should be applied to ensure effective and safe traction. Correct placement of the cup over the flexion point promote maximum flexion of the fetal head, allowing the smallest diameter of the head to pass through the birth canal. The flexion point is located on the sagittal suture, approximately 3 cm anterior to the posterior fontanelle or about 6 cm posterior to the anterior fontanelle. It lies closer to the posterior fontanelle. Importance of the flexion point. Applying the cup over the flexion point is crucial because it maintains flexion of the fetal head. It presents the smallest diameter, the suboccipitobregmatic diameter. It improves the success rate of vacuum delivery. It reduces cup detachment. It minimizes maternal and the fetal trauma. Incorrect placement may lead to deflection of the head, larger presenting diameter, increased failure rate, higher risk of scalp injury. Indication of vacuum delivery. It is indicated in the following situations like prolonged second stage of the labor, maternal exhaustion, ineffective maternal pushing, fetal distress in the second stage, medical condition where prolonged pushing is contraindicated such as cardiac disease or severe hypertension. Prerequisites. Before applying vacuum, the following condition must be fulfilled: should be fully dilated cervix, rupture membranes, engaged fetal head, non-fetal position, no suspicion of cephalopelvic distortion, adequate pelvis, informed consent, empty bladder, availability of caesarean section facility. These prerequisites ensure maternal and the fetal safety. Now I will explain the technique of vacuum-assisted vaginal delivery in a stepwise manner. Vacuum delivery should only be performed after confirming all prerequisites. First, patient should be prepared. Explain the procedure and obtain informed consent. Ensure good analgesia or regional anesthesia. Position the patient in lithotomy position. Empty the bladder with catheterization. Confirm fetal position by vaginal examination. Ensure neonatal resuscitation team is available. Preparation is essential for safety and the success. Then identification of the flexion point. Identify the sagittal suture. Locate the posterior fontanelle. The flexion point is about 3 cm anterior to posterior fontanelle. Correct placement promotes maximum head flexion and delivery of the smallest diameter. Then, creation of negative pressure. Negative pressure should be created gradually. First, increase suction to around 100 to 150 mm of mercury to check proper placement, then gradually increase to 500 to 600 millimeter of mercury. This pressure creates a firm attachment to the fetal scalp and form a swelling called the chignon. Sudden application of full pressure should be avoided to reduce scalp trauma. Then traction. Apply traction during uterine contractions. Encourage maternal pushing simultaneously. Traction should follow the curve of cars initially downward, then horizontal, and finally upward as the head grounds. Maintain steady and controlled traction. Avoid excessive force. Now I will discuss complications of vacuum delivery. First, I will discuss maternal complications, which include genital tract trauma, vaginal tears, cervical lacerations, perineal tears. Second, postpartum hemorrhage due to trauma due to uterine atony, extension of episiotomy, vulval or vaginal hematoma, perineal pain and edema, infection, urinary retentions. Maternal trauma is generally less severe compared to forceps delivery. Now, fetal complications, chignon formation, temporary scalp swelling resolve within 24 to 48 hours. Scalp abrasions or lacerations, cephalohematoma, subperiosteal bleed, does not cross suture line, may cause neonatal jaundice, subgaleal hemorrhage, bleeding beneath scalp aponeurosis, risk of hypovolemic shock, intracranial hemorrhage, retinal hemorrhage, skull fracture. The procedure should be abandoned if no descent after 3 pull. Procedure exceeds 20 minutes, more than 2 or 3 cup detachment occur. If unsuccessful, proceed to caesarean section. These are called the 3 pull rule for safety. Thank you for your kind attention. I hope this presentation has provided a clear understanding of vacuum assisted delivery, including its indication, technique, and potential complications. Vacuum delivery is a valuable obstetric intervention when performed with proper case selection, correct techniques, and adherence to safety guidelines. I welcome any question or discussion. Thank you once again.